So good evening to you all. Just confirm whether the audio and visual is fine. Just give me a thumbs up. Srinivas, Stranger, Sagar, Sushil, Mehboob Alam, yeah, Sagar. So is the audio visual okay? Okay, fine. So the very first message to you, I trust that your exam went well, and I am very hopeful that the good results will come soon and you will bring me the happy news as well at the earliest possible. But today's session is basically to recall some questions which were asked in the anatomy section, and we are going to start with the general embryology. So as I have gathered some of the questions from you people only, the very first question which I got is asking us about the primary action of inhibin. So as we talk about this question, I think it is a repeat question. Action of inhibin. Inhibin is basically given by the Sertoli cells in the testis, and let me show you one diagram that will be clarifying some details. This is basically a feedback mechanism we are talking about, and when we are looking at the testis, in the testis we will have the Sertoli cells, and Sertoli cells will be giving us inhibin. Actually Sertoli cells, they are stimulatory for the process of spermatogenesis, and the sperms, as they increase in number, then there will be release of inhibin, and it is a feedback inhibition. Basically inhibin will go back and it is going to work upon the pituitary. So pituitary, normally it will be secreting follicle stimulating hormone, and that follicle stimulating hormone, again it is having a positive effect on the Sertoli cells, basically on the seminiferous tubules to produce more of sperms. But if the sperm number is enough, then you have to prevent it. So that feedback inhibition is by inhibin. As such, if you are talking about another feedback inhibition, that will be the testosterone, which is working on pituitary. It is negative feedback, and it can also work on the hypothalamus level, because basically it is the hypothalamus which is the master system which is going to control the pituitary, and pituitary is the master gland which is giving us the hormones. So in effect, if you were asked about testosterone, testosterone basically works upon the hypothalamus, but it can also work upon the pituitary. But the question is on inhibin. So as we go back to our question, it is asking primary action of inhibin. So what have you marked in your exam? I hope you have marked it correctly. Primary action of inhibin is, it is not working on prolactin, it is not stimulating FSH, it is inhibiting the FSH. So here the answer will be choice number C, inhibition of FSH secretion, though it can also work upon the hypothalamic LH releasing, but that is not well established. The best answer possible here should be choice number C. Okay, so there was one question here which I could gather in the journal Embryology. Now as we move on to histology, histology you got numerous questions. Let us look at the very first question here. As we are looking at the histology section, this is very first question which we have got, and it is asking about some cell in the slide. Marked cell is secreting which hormone? So was this the question, or maybe the question was framed differently, but here what you see is the thyroid follicles. So what you notice is this is one thyroid follicle. Thyroid follicle is identified by the fact that it will have some colloid thyroglobulin, that secretion will be there, and the cells lining usually they will be simple cuboidal cells, but depending upon the activity, sometimes they can become columnar also if there is more of secretion. If more of secretion, more of endoplasmic reticulum, they become columnar. Normally it will be cuboidal cell lining of the thyroid follicle, but here you are actually looking at the interfollicular area. These cells are slightly larger cells which they have asked, and as you will notice, they are parafollicular C cells. So marking is on the parafollicular C cells, they give C hormone, that is calcitonin hormone. If you talk about the embryology, they will be coming from the ultimobranchial body, that is the remnant of fifth pharyngeal pouch. So remnant of fifth pharyngeal pouch basically will be populated by neural crest cells. So it is the neural crest cells which will be populating the pharyngeal pouch 5, which then attaches with pouch 4, and their ultimate branchial body will be there. In that, the neural crest cell will change into parafollicular C cells, and they will give the C hormone, which is calcitonin hormone. Basically they are working upon the calcium metabolism. So if it is C cell, we are telling it is giving the C hormone, calcitonin should be our answer here. Thyroxine will be inside the thyroid follicle. Adrenaline and prolactin, prolactin means it is about the pituitary, adrenaline about the adrenal gland, but this is about the thyroid gland here. Right. Now as we move on to the next question, again it is a repeat question, and they are this time means repeat topic, you can say, not exactly the same question. Slides may be same, but then they have changed the pattern of asking the question. Sometimes they will mark ABCD and then ask you the type of secretions being given, but here they have given some marker. Now as you look at the options, mineralocorticoid, glucocorticoid, the adrenaline or androgen, you understand that they might be talking about adrenal gland here. Now in the adrenal gland also, how you identify is, towards the outside there will be a capsule. This is the capsule which is some collagen fibers, and then you will have the sequence, as we say, the GFR. So what is this GFR? That is in the adrenal cortex. In the adrenal cortex you will have the GFR, then you will have the adrenal medulla. Now zona glomerulosa, which is little bit darker in appearance, not very prominent here, but glomerulosa. Then a lighter structure will come, which is fasciculata, and then again darker color, which is reticularis, and then again lighter color, which is the medulla. So you will see alternate bands of dark and light variations according to the H&E stain. The very first thing which you notice here, as we have marked, is the capsule on the outside. This is the capsule on the outside, and then you have GFR, zona glomerulosa, zona fasciculata, zona reticularis, and this is the cortex, and down here is the medulla. Medulla is also identified by the fact that it will have lot of blood vessels. As you notice here, let me put some other color. This is some blood vessels. These blood vessels will be numerous in the medulla region, because it is endocrine gland, and whatever secretion like adrenaline it will be giving here will be poured into the blood so that it can be distributed throughout the body. So they are marking the adrenal medulla, and epinephrine, norepinephrine will be coming here. So as such, if we are searching for the answer will be choice number C, adrenaline. Now if we are talking about the zona glomerulosa, which is very little thickness is not so well defined here, but it is the one which will give mineralocorticoid as choice A. If you say glucocorticoid, it will be coming from the fasciculata, glucocorticoid, and if you are talking about the androgens, weakly androgenic like DHEA, it will be given by the reticularis. So here you can write the androgens will come from the reticularis, whereas glucocorticoids will be coming from the fasciculata, and if you are talking about mineralocorticoids, then they will be coming from glomerulosa. So just a brief idea, but the answer should be choice number C here. But medulla was not there, arrow was not at the base, then where was the question? Okay, Shubham, if medulla was not there, where was the arrow? Can you mention? Androgen is the answer. Okay. So they were putting the marker on reticularis then? Okay, right. So Shash and Shubham, as they are mentioning, that it was actually medulla was not there in the picture. Okay. If medulla was not there in the picture, there was capsule and the 3 layers, glomerulosa, fasciculata and reticularis. And if it was reticularis, then you will say weakly androgens. Androgenic means it is giving us something like DHEA. Okay. Now, as we move on to the, so this is again the same diagram, and it may happen that the medulla may not be given. As such, this is the capsule outside. Let me mark it. This is the capsule, and then this is the darker color which we were talking about, the zona glomerulosa, then lighter color fasciculata, then again darker color reticularis, and again lighter color the medulla. So before this it is cortex, after that it is medulla. So alternate bands of darker, lighter, darker, lighter color will be seen, and capsule will be outside, very thin collagen fibers, some connective tissue. Below that you will have a darker area glomerulosa, lighter area fasciculata, then darker area reticularis, and as you are telling, the medulla was not given at all, so let us not bother about that. Then your arrow was on reticularis, and as we have mentioned, sex steroids, weakly androgen, that will be your answer. Glucocorticoids in the zona fasciculata and mineralocorticoids in the zona glomerulosa. So this will give you some orientation. I thought that they had put the marker on medulla, but which is not the case as you are suggesting. Okay, I hope it got clear. Now this is another question, again a repeat question, asking which of the following is a primary lymphoid organ. Now when you say it is primary, primary means the one which will have stem cells, and those stem cells they will be capable of making lymphocytes. So lymphocytes basically are made by bone marrow. So stem cells will be there in the bone marrow, and this bone marrow will be making the lymphocytes, but then some of the lymphocytes, some of the stem cells themselves, they will be migrating towards thymus. So even thymus can have stem cells, and there they will be trained as the T lymphocytes. Let me show you a diagram, there I can explain. So when we are talking about the primary and secondary lymphoid organ, you can see here in this diagram, when we say primary lymphoid organ, they must have stem cells, and stem cells in the beginning they will be in the red bone marrow, and those stem cells can make lymphocytes, lymphopoiesis. But then some of the stem cells they will be given by red bone marrow, but they will migrate to thymus. Now if they have migrated to thymus, in the thymus they will be trained as T lymphocytes, and they are working for cell mediated immunity. But some of the stem cells which were there in the bone marrow, they will be working as B cell, the B lymphocytes later they change into plasma cells, and those plasma cells they will be forming the antibodies. So you can say humoral immunity. When you talk about humoral immunity or antibody based immunity, that is secreted by plasma cells, which are basically the stimulated form of B lymphocyte, and that way we have B lymphocyte working for humoral immunity and T lymphocyte for cell mediated immunity. But both the organs, maybe it is the thymus or red bone marrow, both are considered as primary because of simple fact that they will have stem cells. And then these T and B lymphocytes migrate to the periphery, they will monitor and mount the immune response in the secondary lymphoid organ. So when we talk about the secondary lymphoid organ, you can see here let us use this color. They could be anything like lymph node throughout the body, or it could be tonsils. Tonsils could be lingual tonsil, palatine tonsil, pharyngeal tonsil, or even the eustachian tube, tubal tonsil. So any tonsil, spleen or malt, mucosa associated lymphocyte tissue, that could be Peyer's patches in the terminal ileum, or could be in the appendix also. So mucosa associated lymphocyte tissue is also secondary lymphoid organ, lymphoid tissue. Spleen, tonsil, lymph node, they are all considered as secondary. Okay, so that is about the question. Question was asking about the primary lymphoid organ, and we can answer that if you are talking about primary, either the bone marrow. If bone marrow is not there, then thymus. Thymus is one of the lymphoid organ which will not have reticular fibers. Normally lymphoid organs will have reticular fibers, but thymus has no reticular fibers. It has thymus epithelial reticular cells. They will be making the network. They need network where lymphocytes can be put, distributed. So this question comes, thymus does not have reticular fibers, but if it does not have reticular fibers, then where the lymphocytes will be put? Lymphocytes will be put in a network which is made by thymic epithelial reticular cells. So that is something specific for thymus, and it is a primary lymphoid organ. Liver, spleen or lymph node will be secondary. So we got our answer here. Now as we see, I think most of the questions which appeared, they are repeat question. Epithelial lining of trachea. Before you answer the question, let me show you, this is how it will appear, the trachea, the epithelium. So as we talk about the trachea, maybe trachea or maybe even the bronchus, they will have same kind of epithelium, which is respiratory epithelium. This is a section of the trachea. Trachea can be identified by the fact that it will have a C-shaped hyaline cartilage ring, but it will be deficient posteriorly. So only anteriorly you will have this C-shaped cartilage, posteriorly it will be deficient, and wherever it is deficient you will have this muscle which is called as the trachea muscle or trachealis. So that is the trachealis, which can be seen posteriorly here. It is basically some smooth muscle which is filling the gap which is between the two ends of hyaline cartilage. What we have shown here is the hyaline cartilage. So this is C-shaped hyaline cartilage, and the purpose of having hyaline cartilage is to maintain the patency of the lumen. Trachea should have lumen through which the air will pass. So hyaline cartilage will be only anterior and laterally, posteriorly it will be deficient, and that deficient portion, what we see, will be actually having this smooth muscle which is trachealis, which is posteriorly. So these are also your questions which have come earlier. And if you talk about the epithelium of trachea or maybe bronchus, it is, as you can see, we can mention, first of all you will see the nuclei are at various levels. Some nuclei at a higher level, some at the mid level, some at the lower level. So multiple level of nuclei, giving the false impression of being multi-layered, but it is not multi-layered. It is actually each cell touch the basement membrane, cannot be multi-layered. That is why we say it is not stratified, it is pseudo stratified. So the very first thing which we notice is multiple level of nuclei, giving the impression of stratified, but it is not stratified, so it is pseudo stratified. Second thing you will notice, these are the cilia which can move the mucus, trapped dust particle, bacteria, cough it out through the respiratory or oral cavity. So this is cilia. So it is pseudo stratified, ciliated, and then you will have columnar cells. Now how do you know it is columnar cell? Because you will find there is quite enough amount of cytoplasm above the nucleus. So if you have lot of cytoplasm above the nucleus, that is the typical feature of a columnar cell. So pseudo stratified, ciliated columnar cell with goblet cell. So you can also identify goblet cells here. As you will notice, these are goblet cells. They will have this mucus which will stain lightly, and they appear like goblet where people take wine in goblet, something like this. So the upper end of the goblet, this is how the goblet cell appears. When it is the upper end of the goblet appears like the goblet cells appear like that. So what is the full name? What is trachea lined by? Trachea or bronchus, they are lined by pseudo-stratified ciliated columnar epithelium with goblet cells. And once you have that information with you, let us go back to the question, epithelial lining of trachea. So as we search for the answer, epithelial lining of the trachea, simple columnar, ciliated columnar, non-ciliated cuboidal, pseudo-stratified ciliated columnar. So the answer should be pseudo-stratified ciliated columnar epithelium, but with goblet cells also. They will have goblet cells also. If you say non-ciliated cuboidal, that could be in the respiratory bronchiole. This you can find in the respiratory bronchiole, which are non-ciliated and cuboidal. And if you say ciliated columnar you will find in the terminal bronchiole. So this will be in the terminal bronchiole. Terminal bronchiole will then continue as the respiratory bronchiole. Terminal bronchiole is conducting pathway. Respiratory bronchiole is the respiratory, now begins the respiratory pathway. So if you say simple columnar, you may see in the respiratory tract, but simple columnar usually it will be with cilia, and though you can see simple columnar, there is no issue with that, but anyway, if we are asking for trachea, the answer should be choice number D. And then I think that is all we got in the histology section, and then we can move on to osteoarthology section. Yes. Now as we talk about the osteology, or rather say arthology, because they have not asked about bones, they have asked about joints. Repeat question once again, and asking about epiphysio diaphyseal joint. Before we try to answer this question, we will look at this diagram. When a baby is growing, that time there will be primary center of ossification, and that primary center of ossification will be giving us the diaphysis. So shaft means it is the diaphysis. So there will be a primary center of ossification which will give us the shaft or the diaphysis, and there will be a secondary center of ossification which will be giving us the end or the epiphysis of the bone. So embryologically, the primary center of ossification gives the shaft, whereas the secondary center of ossification will give the epiphysis, and between the two you will have this plate of cartilage, that is hyaline cartilage, which is also called as the growth plate. So here you can see this is basically the growth plate. Growth plate is hyaline cartilage. So one bone is connected to other bone with the help of some hyaline cartilage, and this is a primary cartilage joint, synchondrosis. This is a synchondrosis primary cartilage joint, and it is immobile. So primary cartilage joints are immobile joints, and later when the baby has already reached puberty and past the age of puberty, that time this cartilage will be replaced by bone, and there will be a bony fusion which is called as synostosis. But be careful, synostosis is bony fusion and it is not a type of joint. If the examiner is asking about type of joint, you cannot answer it as synostosis. So what should I answer? Let us go back to the question. You have to be careful about such questions, because a slight change of the language may change your answer. So what is this question asking? This question is asking epiphysis, that is the end, and diaphysis, that is the shaft. So shaft and the end of the bone, which kind of joint? See, they are asking joint. If you say joint, then you should always answer it as primary cartilage joint or synchondrosis. So your answer will be choice number A. They might ask you the other way. They'll ask you what is the future of epiphysio-diaphyseal joint. If they don't mention the joint, what is the future of epiphysio-diaphyseal joint, that time you can say that it is supposed to become synostosis or bony fusion. But then synostosis is not a joint type. Whenever they have put a term joint, you cannot answer it as synostosis, though this is also correct. But that should not be the answer. Answer will be only synchondrosis. And obviously, if you say epiphysio-diaphyseal joint, it must be in young people, youngsters, not in the adults. In adults, there is no such joint. So keeping your answer as choice number A, you can move further. Okay. Answer is A, yes. Now there is one other question which is asking about, again a repeat question. Repeat in the sense means these type of questions, they would have appeared in the last 5 years. So that is what I will consider as a repeat. Sometime it can be more than 5 years also, but I believe most of these questions what I am telling you as repeat, they have appeared in the last 5 years only, because we monitor your system and we do remember what kind of questions have been asked to you. So what do you think? First carpo-metacarpal joint. Before we try to answer this, you can see one diagram which we have taken, and in this diagram, say we are focusing upon first means thumb, first carpus and metacarpus. So we have magnified it, carpus and metacarpus. This is metacarpal, that is carpal. So which carpal bone will be that? Laterally we have the radius bone. Radius is articulating with scaphoid, and scaphoid is then articulating with the capitate. Trapezoid, this is trapezium. So this will be trapezium and then the base of first metacarpal. So scaphoid is one of the carpal bone which will be then articulating, because it is wrist joint. So the next is trapezium, and trapezium will be then articulating with the base of the first metacarpal. So they are basically asking about this joint, carpo-metacarpal joint, and this is x-axis you take, it is concave, y-axis you take, it is convex, concavo-convex, and concavo-convex appearance whenever you get, you will call it as the saddle synovial joint. In the upper limb you have this sternoclavicular joint which is also saddle synovial, and the first carpo-metacarpal joint where you can do this flexion, extension of thumb, or even the abduction, adduction of thumb, or even circumduction. So if you are talking about the first carpo-metacarpal joint, it is highly mobile, flexion, folding, extension, unfolding, abduction, going away, adduction, coming back, or circumduction. They are basically happening at first carpo-metacarpal joint, and it is saddle synovial joint, multi-axial joint. So little bit of more detail, but anyway we got our answer. In the upper limb you can remember two examples of saddle synovial. One I have told you, sternoclavicular, and sternoclavicular joint also, when does it work? When you are doing abduction. This abduction movement, it is working, though abduction is basically at the shoulder joint, but you have to use sternoclavicular joint also, and other movements also, like shrugging of shoulder. In shrugging of shoulder you can put your finger here and you will feel that when you are shrugging the shoulder, this joint is having some movement, even moving the shoulder anterior posterior. So it participates, though basically movement will be at the shoulder joint, but it is participating. That is also saddle synovial joint, multi-axial you can say. Now coming back to our question, if they are asking the synovial joint, first carpo-metacarpal, we already mentioned it should be saddle synovial joint. If you are talking about the ellipsoid, wrist joint and metacarpophalangeal joint, wrist and knuckle joint. So wrist joint and metacarpophalangeal joint, the knuckle joint, both of them are ellipsoid. You can say wrist joint and the knuckle joint, both of them are ellipsoid. Saddle, we have given two examples, one already is there, first carpo-metacarpal, the other we have, this is first carpo-metacarpal, second we have told sternoclavicular clavicular joint. Ball and socket, shoulder joint, hip joint. Hinge joint, if you are telling interphalangeal joint, they are hinge. Elbow joint is hinge. So elbow is hinge, the interphalangeal joints are hinge. So you should have at least those questions which come, you should know their types. But here answer will be choice number B. The question was shrugging of shoulder. Yes, there was a question on shrugging of shoulder also. These questions never came in exam. Are you sure about that? Khushi, Shubham, this was not there. First carpometacarpal joint was not there. Okay. What about the previous one? Epiphysio diaphysial. But why the students, you people only gave the question. Okay. So joint between epiphysis and diaphysis was there. Okay. Anyway, so I don't know, like that means we are wasting our time unnecessarily discussing some useless questions at the moment. They are not useless, but at the moment appear to be useless. Okay, that we'll discuss, shrugging of shoulder, yes. Anyway, sometime there are funny things happening around, and this is one of the funny thing. I am not looking at the chat and just discussing things just for the sake of it. It was there in 2023. Okay, anyway. So epiphysio diaphysial was there, that is fine. So the first thing is, I should ask you whether the question was there at all or not before I start discussing. So tell me, was this question there or not? This is neuroanatomy now. So neuroanatomy, was this question there or not? Okay, so fine. Coronal section of the brain, they have taken coronal section, removed the anterior part of the brain and looking at the brain from the front view, and okay, right. So as you can see, what we find here is some white matter. Question was on scaphoid fracture, yeah, that I understand. So this is basically some axons which are coming like this, and these axons is basically the projection fibers, the internal capsule. So they are putting the marker on internal capsule, which is projection fiber, projecting from the higher brain center to the lower brain center, vice versa, going up and down. Descending fibers, ascending fiber. Ascending fibers are sensory, descending fibers are motor fibers. So projection fibers, they are ascending fibers which are sensory, descending fibers which are motor, and that is internal capsule. Internal capsule is basically sandwiched between, if you remember your embryology, in embryology we discussed that there will be caudate and lentiform together, and it will be passing between the two. So if we draw it like this side, right side, in the beginning we will have the caudate to the inside, medial side, and lentiform is always lateral, and together this is called as corpus striatum. So embryologically we had what is called as corpus striatum, and in corpus striatum then this internal capsule comes and it will be bifurcating the two like this. So this is internal capsule. So when internal capsule comes, lentiform is always lateral, L for L, lentiform is always lateral, you should remember, and caudate is medial. So what you are seeing here, or on the other side I can show, this is basically the caudate nucleus, this is caudate, and the lentiform will be lateral like this. Now this is coronal section, sometimes they can give you sagittal section also. The answer to this question is obvious that they were asking about internal capsule, but then let me give you some more details. Answer will be choice number A, but let me give you some more details because sometimes they can ask you about basal ganglia. So, same diagram and more detail. So, as I am suggesting, caudate will be medial and lentiform will be lateral. Lentiform means it is two structures. Lentiform means lens shape, and it will be lens shape, as you can see in this diagram also, and it is basically the outer putamen, inner globus pallidus. Internal capsule is passing between the caudate medial and lentiform lateral. So, when we were talking about internal capsule, it was like this. This is internal capsule. This is the internal capsule. Now, when you talk about the basal ganglia, never include thalamus in that, though thalamus is connected to basal ganglia, but thalamus is not a part of basal ganglia. So, what are the parts of basal ganglia then? Basal ganglia, you have caudate nucleus, you can put the numbers. First you have caudate nucleus, number 2 you have putamen, number 3 you have globus pallidus. These are structural nuclei of basal ganglia. Basal ganglia, structural nuclei, caudate, putamen and globus pallidus. Then it has 2 functional nuclei. And what are the 2 functional nuclei? That you can write here, number 4 and number 5. So, one is substantia nigra, which is in the midbrain, and the other is subthalamic nucleus, which is under the thalamus. That is why the name is subthalamic. So, under the thalamus, subthalamic nucleus. So, these are 5 components of basal ganglia, 3 structural nuclei, 2 functional nuclei. Thalamus is connected to basal ganglia, but is not included as a part of basal ganglia, that you should be careful about. So, this is again a coronal section taken right to left and anterior part of brain removed, and then you are looking from the front view. This is legendary question. After some years this question may die. This question cannot die, let me tell you, because they can make lot of questions upon this. Maybe in FMGE they are not asking, but they can ask you the connections, means it will be then anatomy plus physiology. And not only this anatomy plus physiology, they can add medicine into that. So, but you are correct that they will be fed up by asking the same question again and again. Maybe after some time they will stop asking, but I have seen this question for last 15 years. Last 15 years they have been asking basal ganglia and these same names, and maybe because it is important clinically also, it is relevant. Okay, great. Corona radiata. Corona radiata will be still further. This will be corona radiata. When it goes to cerebrum, then it will be corona radiata. This is corpus callosum. Anyway, let us continue. So, this was the first question. Now, tell me, let me start with this statement. Did the question come or not? And surprisingly, all of these are repeat questions, and which is good for you, because you people are always instructed to practice previous year questions, and if you have, then you would have done better in your performance will be good. This was not there. Devashish is telling yes. Chhota doctor is telling it was not there. Shubham Gahi is telling it was not there. I cannot understand, if this question was not there, your friends only they are telling us. So, they are having some déjà vu or what? Okay, anyway, if it is not asked, then we will not spend much time. I will just give the answer. Corticospinal tract means it is pyramidal tract. Pyramidal tract, pyramidal decussation in the lower medulla. It is a repeat question again, but if it was not asked, then we should not spend much time on this. It is lower medulla. Lower medulla will have pyramidal decussation, and pyramidal tract is basically the corticospinal tract what they are asking. Okay, if it is not asked, then why should we put our efforts on this unnecessarily? Okay, so that is about neuroanatomy. Let us go to head neck. In the head neck region, I think more questions have come. So, tell me whether this question came or not. Okay, so it was there. Shubham is telling it was there. Now, a mother is touching the anterior aspect of the scalp, find a defect in the skull bone. You know, you yourself must have felt quite often. That is about anterior fontanelle. Now, if it is anterior fontanelle, Vivek, Prajesh is telling no. I think this came because most of you are telling yes. So, before we try to answer the question, let us look at this diagram looking from the lateral view of the skull, and you will find there are 4 of them, 4 fontanelle. Fontanelle means when the baby is growing, the brain is growing. So, to let the brain grow, the bones, they are not yet fused and there is a gap between the skull bones, and anyway they are membranous bones, intramembranous ossification, and later this membrane which is in the fontanelle will also become ossified. Now, there are 4 of them which we should know, like as the name will be given. Anterior fontanelle, which it is on the anterior side between frontal bone and the parietal bone. This is the anterior fontanelle, as you will notice, and then you will have this posterior fontanelle. This is the posterior fontanelle. Then you have the posterolateral fontanelle, which is mastoid, as you see, and then the one where you have pterion. So, that is anterolateral fontanelle. Now, here our focus is that which one is going to fuse first. Always answer number 1 as the posterior fontanelle, because it will be 2 to 3 months post birth. As the baby is born, it will be disappearing, the membrane will be ossified and it will disappear. So, here the very first one to disappear is posterior fontanelle. Number 2, you should say this one, that is again 2 to 3 months, but some books will say 6 months. So, this is anterolateral fontanelle where you have the pterion also H-shaped suture. So, that is the second to disappear. It is 2 to 3 months post birth, but if you look at some of the authors, they will say 6 months. So, in a sequence, if you want a sequence, first to disappear is posterior, second to disappear is anterolateral, third to disappear is posterolateral. So, this is the third one in sequence, and on an average you can say 1 year, 12 months, but then 6 to 18 months the range. So, if you are talking about the posterolateral fontanelle, the gap between the skull bones, then it is on an average 12 months, but then if you want a range 6 to 18 months, and be careful, different authors give different values. That is what in your question also they have given some values which actually do not match with the standard textbooks. And last to disappear will be anterior fontanelle. The mother was touching this one, and you can also touch this one, whether to, if the baby is dehydrated, it will be depressed, and if there is hydrocephalus, it will be bulging out. So, those things, hydrocephalus, bulging out, and if it is depressed, could be a feature of dehydration in the baby. So, that can be detected by feeling the anterior fontanelle, and 18 to 24 months is generally spoken. So, within 1.5 to 2 years it will disappear. But as such, if you look at your question, the options which were given, if it is persisting more than 2 years, then there could be several reasons. Even hydrocephalus can lead to that. Rickets is one of the feature, yes, as you have mentioned. Ayush, tomorrow is your anatomy viva. So, all the best. Give some wonderful answers so that your teacher also become happy that some great doctor, some great budding doctor is the one which they are training now. Mother while touching anterior fontanelle. Okay, so this is anterior. So, I hope they were talking about the anterior fontanelle only, and because it is 1.5 to 2 years post birth, we will go for the maximum here, and choice D should be our answer. So, 13 to 24 months, though it should be 18, as I am suggesting it should be 18 to 24, 1.5 to 2 years, but different authors use different values. So, cannot actually comment upon these values, but most probable answer is choice number D. Image was also given. Arya Nag, this question was not there. I told you that when I start discussing the question, then only you tell me. Once I have discussed the question, then what is the use of telling it question was not there. That means there were two set of papers, one set of paper, second set of papers. Some students got this question, other students did not get this question. That is what I can understand. Devashish is telling question is not, Devashish is telling question is there. Shubham Gai is telling question is there 100%. And then this question was not there. Arya Nag is telling it was not there. Anyway, so humor in life. Anyway, let us move on to the next one. Which vessel developed from the left of six? I don't see any new question, they are all repeat questions. Now tell me, yes, Chhota doctor, next question. So tell me first whether this question appeared or not. This question was there, but image, okay, I will show you the image also. So it was there, huh? Okay, great. So which vessel developed from the left sixth pharyngeal arch? Sixth pharyngeal arch, if you say, then we are supposed to talk about the pulmonary arteries, maybe the right pulmonary artery or left pulmonary artery, but then we say left is left and right regresses. We are talking about ductus arteriosus. So in the beginning ductus arteriosus is on both sides, but then the right ductus arteriosus will regress and left is left. So left side the ductus arteriosus will be left. So sixth pharyngeal arch artery also gives ductus arteriosus, but if it is left side then it will be normal, and that is why our answer will be ductus arteriosus. If you are talking about subclavian artery, then it will be coming from the fourth arch partly. Fourth arch partly it will give, and common carotid artery will be coming from the third arch, and arch of aorta. If you say arch of aorta, in the beginning it is the aortic sac, but then it is the left sided fourth arch artery. So it is the fourth arch artery but on the left side. So arch of aorta will get contribution fourth arch artery on the left, and fourth arch artery on the right side will form right subclavian artery. Right subclavian artery, fourth arch artery, right subclavian. If you say left subclavian, then intersegmental arteries only, they contribute. They contribute on the right also, means lot of details for subclavian. But anyway, arch of aorta, left sided fourth arch. If it is common carotid, both side third arch artery. If it is right subclavian, fourth arch on the right side. And the answer is ductus arteriosus. And as you are telling, there was a diagram, it was a diagram based question. So the same thing which I mentioned, I will repeat again. What happens is arch number 1, arch number 2 and arch number 5, they are almost regressing, not leaving behind much. So basically it is arch number 3, 4, 6 which are working. What is arch number 3 giving us? As you say arch number 3, let us use this color. Arch number 3. Arch number 3 will be forming the common carotids and internal carotid also. Common carotid, internal carotid. So that is third arch. Then what about the arch number 4? As we mentioned, arch number 4, if you look at the right side, part of right subclavian artery, and if you look at the left side, it will form part of arch of aorta. So that part of arch of aorta. This is fourth arch. So third arch will form common carotid, beginning of internal carotid, and fourth arch it will be on the right side forming part of right subclavian artery, and on the left side part of arch of aorta. And when we talk about our question was on the sixth arch. As you can see, the sixth arch will form pulmonary artery, maybe on the right side or left side, and also ductus arteriosus, but then pulmonary artery will persist on both sides and ductus arteriosus will be only on the left side. So left is left, right regresses. Right ductus arteriosus will regress and left is left. And that is why you will see the nerve, which is recurrent laryngeal nerve. Recurrent laryngeal nerve will be the nerve of sixth arch, and it will be hooking under the ductus arteriosus. It will have a long course also. Left recurrent laryngeal nerve is longer because it is hooking under the remnant of ductus arteriosus. And what is the remnant of ductus arteriosus? The remnant of ductus arteriosus is ligamentum arteriosum. So what is this? This is recurrent laryngeal nerve, of course on the left side, left recurrent laryngeal nerve. So left recurrent laryngeal nerve is longer because it is coming and hooking under the ductus arteriosus remnant, which is ligamentum arteriosum, whereas because the right sided ductus arteriosus disappears and fifth arch is already disappearing. So right recurrent laryngeal nerve, recurrent means it will come back. So if you look at the right side, it will be hooking under subclavian artery, subclavian artery. That is why the right sided recurrent laryngeal nerve is shorter course, because it goes back from the neck region only, whereas the left one enters the thorax and again comes back to neck region. And this diagram I will show again, it is here. This is the difference why the left nerve becomes longer. So this is vagus nerve, and vagus nerve is giving us what is called as recurrent laryngeal nerve, and this recurrent laryngeal nerve is left side and it is longer as compared with the right. The right recurrent laryngeal nerve is shorter because it is hooking under the subclavian artery. The right recurrent laryngeal nerve will be hooking under the right subclavian artery because there is no ductus arteriosus on the right side, and but here you do have ductus arteriosus on the left side, and it has to, the recurrent laryngeal nerve has to hook under the, because it is a nerve of sixth arch, so it has to hook under the artery of sixth arch, which is ductus arteriosus. And I think this question came, when you are operating on ductus arteriosus, which nerve is prone to injury? So if you are operating on ductus arteriosus, some babies can have PDA, patent ductus arteriosus. So if you have patent ductus arteriosus, that is persistence of sixth arch artery, then the nerve at risk of injury is left sided recurrent laryngeal nerve. So that is also one question which came, I believe. Left arch of aorta surgery. Left arch of aorta surgery. Was that a question? Arch of aorta is left only. Sometimes you can have right aortic arch. Sometimes you may have right aortic arch, otherwise arch of aorta is left sided only. Neck and thoracic surgeries, yes. Vocal cord palsy, because of which surgery? Vocal cord palsy. Vocal cord palsy, are you talking about that question where you were doing needle cricothyrotomy? There was a question in surgery, I think ENT, doing needle cricothyrotomy, and there was some injury that could lead to injury of these recurrent laryngeal nerve. Vocal cord palsy could be there. Was this question there? Ductus arteriosus surgery question was there, the one which I have discussed. Recurrent laryngeal defect because of which surgery? Recurrent laryngeal nerve defect can be due to working upon ductus arteriosus, number one. Number two, mostly thyroid surgeries. In thyroid surgeries, if you are not careful, you may damage this recurrent laryngeal nerve, and that will lead to vocal cord palsy, whichever side you have damaged. Mostly it is thyroid surgeries which compromise recurrent laryngeal nerve. थायराइडक्टोमी से वही थायराइड की सर्जरी होगी कोई, पर वो क्वेश्चन मेरे पास है नहीं, कैन नॉट कमेंट अपॉन दैट. सो आई थिंक दिस वाज द क्वेश्चन. सर्जिकल प्रोसीजर, a surgical procedure was being carried out upon ductus arteriosus, and the nerve which is lying close relation should be identified and avoided. So you should not be avoiding, you should not be damaging the left sided recurrent laryngeal nerve, left sided recurrent laryngeal nerve, because if you are talking about ductus arteriosus, then it should be choice number D. Yeah. So this needle cricothyrotomy, I think it was surgery question, ENT or surgery. I usually will be taking some of the other subjects like surgery or ENT ortho if it has some anatomical relations. Otherwise, surgery means surgery people should handle. Until otherwise it has some anatomical knowledge to be applied, I leave it. Okay, right. So now this is a very dangerous question, though this time it was not dangerous. But first of all, was it there or not? Yes, Shoda doctor, this is the next question. You are performing some GI endoscopy, and while doing that, there is a perforation of esophagus at 25 centimeter from incisor. Now, which structure? Now, it is a very controversial question, but in here I think the examiner was very happy somehow. If you have gone through previous year questions, then there shouldn't be any problem. So, if it is 25 centimeter from upper incisor, what do you think? Arch of aorta, isn't it? Right main bronchus does not come, it is left main bronchus which has to come. Cricopharyngeus is the one where you begin, and diaphragm is the one where you end. There are some surgery people, ENT people 3 narrowing, anatomy people 4 narrowing, radiology people 5 narrowing. So, that is why I told you it is controversial, and on the top of that, I do not want to complicate the picture, but you know, if they ask you 25 centimeter, better answer will be left principal bronchus. Left principal bronchus is better answer than arch of aorta if they are asking 25 centimeter from upper incisor, and I have a reference of a surgery book for that. So, 25 centimeter, because they have not given left principal bronchus, no issue, we have simply given the arch of aorta, but if both options were there, because the question already has come and it is a controversial question. If they ask you 25 centimeter from upper incision, my first answer will be left principal bronchus. And why left principal bronchus, why not arch of aorta? I have my reasons for that. I have a standard textbook reference where left principal bronchus is preferable over the arch of aorta. Let me explain the detail now. It is a highly controversial question, but anyway, if it is not needed, why should we create any controversy unnecessarily? So, this is from the front view, this is from the side view, and that is side view only. You have given some barium swallow, and you are taking the fluoroscopic picture, and this is lateral view. So, as you see, this is the beginning of the esophagus at the level of cricoid cartilage. You will start, and from there you will have this trachea, then the arch of aorta, then left principal bronchus, the left atrium, and then the diaphragm. So, as you can see, the very first thing will be at the beginning of the esophagus, there is cricopharyngeal sphincter. So, that will be number 1, cricopharyngeal sphincter, beginning cricopharyngeal sphincter, and that is at the vertebra number C6 and 15 centimeter from upper incision, like when you put a Ryle's tube. You are putting a Ryle's tube, and on the Ryle's tube there will be a marking 15 centimeter. On the Ryle's tube you have marking 15 centimeter, that means your Ryle's tube is now entering esophagus. Do not poke your Ryle's tube here and there, you might perforate the esophagus, means damage the mucosa. So, beginning, that is cricopharyngeus, C6 vertebra and 15 centimeter from upper incision, that is one. Now, number 2, it is the arch of aorta. So, when it is the arch of aorta, you see these are the narrowings which we are talking about, these narrowings, these narrowings, these narrowings. So, number 2, as you can see, aortic arch. Now, normally in Gray's anatomy also it is given 23 centimeter. How come it became 25 then? So, some authors telling 23, some authors telling 25, that is the controversy. And then number 3, it is the left principal bronchus. So, when it is the left principal bronchus, that is number 3, and that is about T6 level 28 centimeter. So, as you see, this is Gray's anatomy values. Gray's anatomy does not give 25 at all, and because it does not give 25 at all, that creates controversy. But if you look at ENT books like Dhingra, or if you look at Sebastian surgery, they will give you 25. And by giving 25, what they do is they make it as bronchoaortic narrowing. Bronchoaortic means they are considering it superimposed, but as you can see they are not superimposed. One is higher, one is lower. So which value should I remember? Basically, best is to follow Gray's Anatomy. These are the values given by Gray's Anatomy. Best is to follow that, and then you modify according to the type of questions you keep getting. So to keep it simple, I am not complicating it. This is left atrium, but then if it is only a case of left atrial hypertrophy, if there was a case of left atrial hypertrophy, then it will compress the esophagus. Left atrial hypertrophy, then this compression will come. Normally it should not be there. And then lastly, when it is passing the diaphragm, so when it is passing the diaphragm, that is T10 vertebra level and 40 centimeter from upper incisor. So just have a overview, but it is highly controversial topic. Anyway, if we are getting our answer, our job is done. It is arch of aorta, but be careful, if left principal bronchus was there, I would have taken that as my first answer, arch of aorta as second answer. But here it is arch of aorta. I ate 10 eggs at 12. Only 10 eggs you ate, only 10 eggs, why not 20 eggs? I usually won't give any mnemonics, because mnemonics, if you want, you should make your own mnemonics. Mnemonics can be very dangerous because they are not your own. You will remember the mnemonics, but you will forget the extension of the mnemonic in the exam hall. So they are dangerous. It is always better to teach in such a way that you remember it the way it is, and some people find themselves comfortable with mnemonics. So it is good for them, but I usually avoid using mnemonics and giving mnemonics. Next question, yes. Chota doctor is keeping us on track. Now, nerve injured surgical procedure, ear region, ear, and resulted in lag ophthalmos. Lag ophthalmos means you are trying to close the eyelid and it is not closing, either it is slowly closing or it is not closing at all, lag ophthalmos, and likely nerve injured. So what does it close? Which muscle is closing it? It is called orbicularis oculi, and orbicularis oculi, which nerve is supplying? It is the facial nerve. So there shouldn't be any much problem at all, facial nerve. Maybe when you are working on ear, because auricular branch of vagus and facial nerve coming from the stylomastoid foramen, it will come here and then it will be moving into parotid salivary gland. So if you are working on ear, you may damage some axons of facial nerve. So it may happen, it is facial nerve. Lag ophthalmos means inability or lagging behind of the lid to close the eye, and orbicularis oculi, so 7th nerve. Fallopian canal, yes, posterior wall of middle ear cavity, posterior wall of middle ear cavity, that is what you are talking about. Okay. Now this one, patient with cavernous sinus thrombosis. Patient with cavernous sinus thrombosis and the nerve lying close to medial. Action, to check the action of the nerve. So let me show you a diagram of the cavernous sinus front view. When you look at the cavernous sinus from the front view, pituitary gland, lateral to that is cavernous sinus. So you have taken a coronal section looking from the front view, pituitary gland, lateral to that is cavernous sinus, then you have magnified on the left side, left cavernous sinus magnified. So looking from the front view, left cavernous sinus magnified, and you will see that there is one nerve which is running close to medial wall, and that nerve which runs close to medial wall is the abducent. Abducent nerve runs inferior lateral to internal carotid artery, which is also a content of cavernous sinus. So abducens nerve is running inferior lateral to internal carotid artery, which is also a content of cavernous sinus, but both of them are near the medial wall. If they are near the medial wall, then who is in the lateral wall? In the lateral wall, you will find now number 3, 4, number 3, 4, 5, 1 and 5, 2. So 3, 4, 5, 1 and 5, 2. What is this 3, 4, 5, 1, 2? 3 is oculomotor nerve, 4 is trochlear nerve, 5, 1 is ophthalmic trigeminal and 5, 2 is maxillary trigeminal. So these nerves are in the lateral wall. Now number 3, 4, 5, 1, 2. And the medial wall you have, it is not medial wall but more medially, it is actually in the center. This abducens nerve is running in the center but comparatively more medial. So abducens nerve and internal carotid artery, they are running more medially. They are talking about abducens nerve. So if abducens nerve is compromised, what is the formula? Formula, you know, the formula of eyeball muscle, LR6 SO4 remainder 3. You are talking about 6 nerves, so lateral rectus. So what will happen if there was a cavernous sinus thrombosis and 6th nerve is compromised? Lateral rectus will not work. And what if lateral rectus is not working? If lateral rectus is not working, then you will see this. What is this? If the lateral rectus is not working, there will be internal strabismus, squint will be there. So right sided abducens nerve is not working. If right sided abducens nerve is not working, the person is looking straight. But then if lateral rectus is not working, then medial rectus is more powerful. It will keep the eye in medial squint, So this patient is having medial squint because right sided 6th nerve is not working, right sided abducens nerve is not working, lateral rectus is not working. If lateral rectus is not working, then medial rectus become more powerful. If medial rectus become more powerful, there will be a medial squint. Actually, it is the earliest sign of cavernous sinus thrombosis nerve lesion. The earliest sign of cavernous sinus thrombosis involving the nerves is medial squint only, and after some time it can proceed to what is called as external ophthalmoplagia. External ophthalmoplagia means all the nerves will be involved. It starts with 6, then it will involve 3, 4 also, and once it is involving 3, 4 also, the eye will come in neutral position, cannot move at all, up, down, wherever, it cannot move. So it begins with medial squint, but then later it will involve number 3, 4 also, and then the eye will come back to neutral position and will become still eyeball. External ophthalmoplagia means still eyeball, and that means cavernous sinus thrombosis has become really severe. That is a sign. If you find a patient with still eyeball and feature of cavernous sinus thrombosis, that means it is very dangerous now, because it has involved almost all the nerves which were passing, the nerves which were passing even in the lateral wall of the cavernous sinus. After prolonged labyrinthine infection, there is loss of vision because of, this is due to, ऐसा कुछ question था. After prolonged labyrinthine infection, inner ear infection, there is loss of vision. Loss of vision. Loss of vision. Labyrinthine infection से vision का क्या लेन देन है? 8th nerve और 2nd nerve. लॉस ऑफ विजन या कोई स्क्विंट वगैरह था? पल्सेटाइल टोसिस, प्रोटोसिस. ये देखना पड़ेगा क्वेश्चन, अगर कोई ऐसा क्वेश्चन आया था तो मेरे पास तो अभी तक डिटेल आए नहीं. ठीक है, देख लेंगे, we'll check. So that was on head and neck region, I believe, and now we move further to the thorax region, and in the thorax region there are some questions. One is this: first of all, tell me loss of vision with squint. Loss of vision with squint, inner ear का infection है और loss of vision हो गया. काफी दूर का कनेक्शन हो गया तो हाँ ठीक है, इसमें आंसर आपने सही लगाया है. So it is asking arrow marked vein, and where is the arrow? It is actually here. One vein is also visible. This is the cardiac apex. So interventricular groove, anterior interventricular groove. So if this is the anterior interventricular groove, here you will have anterior interventricular artery, and following the anterior interventricular artery is the great cardiac vein. Great cardiac vein begins at the cardiac apex. Now when you say the great cardiac vein will begin at the cardiac apex, where it will go? From here the great cardiac vein will begin at the cardiac apex, will follow anterior interventricular artery in the anterior interventricular groove, and then it will go around the heart, behind the heart. And why is it going around the heart, behind the heart? Because it has to drain into coronary sinus, which is posteriorly seen. So you have to reach posteriorly and then it will drain. So let us look at the course of great cardiac vein, but then there is a small cardiac vein also, and small cardiac vein will begin somewhere here and it will also go posterior. But why the small cardiac vein is also going posterior? Even the small cardiac vein is going posterior because that is where coronary sinus is there. They all drain into coronary sinus. Most of them will drain into coronary sinus, which is in the coronary sulcus but posteriorly. So they are going posteriorly to drain into coronary sinus. That is small cardiac vein. Yes. Okay. What about the middle cardiac vein? Middle cardiac vein, their names are: small cardiac vein means small lumen, great cardiac vein means bigger lumen, and middle cardiac vein means mid size. So small size, mid size and large size lumen, the amount of blood. More amount of blood, great cardiac vein. Less amount of blood, small cardiac vein. And moderate amount of blood, middle cardiac vein. But where is middle cardiac vein? Cannot be seen from here, can be seen from posterior view. So let us make this heart transparent, and when you make the heart transparent, then you can see all the veins. So that is what we have done here. We have made the heart transparent. Again you can start with the great cardiac vein. So where the great cardiac vein begins? Great cardiac vein actually begins at the cardiac apex, and then what is it doing? It is running in the anterior interventricular groove, and then it will take a turn and go posterior. And why is this going posterior? So that it can drain into coronary sinus, which is lying posterior. Let us represent the posterior course in different color. Now it is running posteriorly, and this is coronary sinus where it will drain. So coronary sinus is present in the coronary sulcus but posteriorly. So yellow is posterior. What about the small cardiac vein? Small cardiac vein begins anteriorly, it will begin anteriorly, but then it will go posterior. So small cardiac vein will begin anterior. It is a continuation of the right marginal vein. Right marginal vein will continue as small cardiac vein. So right marginal vein is also anterior, and small cardiac vein begins anterior but then goes posterior. And when it goes posterior, I will change the color. Now it has become yellow and it will drain into coronary sinus. Which other vein drain into coronary sinus? Middle cardiac vein. And where is middle cardiac vein? It can be seen only from posterior view of the heart. So most of it can be seen only from posterior view. So I will show only in yellow color. This is the middle cardiac vein, and it is also draining into coronary sinus. So there are three major veins. Middle cardiac means middle size lumen, great cardiac vein means great size lumen, and small cardiac vein means small size lumen, depending upon amount of blood they are carrying. But there are some veins which do not drain into coronary sinus, and the veins which do not drain into coronary sinus are called anterior cardiac veins, and they are draining directly into right atrium. So why they are draining into right atrium? Because all venous blood should drain into right atrium, because then right atrium will push the blood into right ventricle, will push the blood into lungs for oxygenation. Veins mostly they should drain into right atrium, because then right atrium will drain this venous blood into right ventricle, then to the lungs for oxygenation. You mean to say coronary sinus will also drain into right atrium? Yes, coronary sinus will also drain into right atrium, but can be seen from posterior view. So even coronary sinus will drain into right atrium, The point is, if there is a coronary sinus thrombus, which vein will escape the injury? If there is coronary sinus thrombus, which veins will escape the injury? Your answer is anterior cardiac vein will escape the injury. Why anterior cardiac vein will escape the injury? Because they do not drain into the coronary sinus. And which vein will be involved in coronary sinus thrombosis? These three veins. Why? What will happen to them? They will be dilated because they are unable to drain the blood. They will become dilated, elongated, tortuous. You can have cardiac vein varicosity also. If these veins are unable to drain properly into coronary sinus, they will become dilated, engorged. But in coronary sinus thrombosis, these veins will escape because they drain directly into right atrium. Okay. Okay, Chota doctor is telling this is not asked. फोर दिन तक चलेगा क्या रिकॉल? क्वेश्चन था ही नहीं क्या? This question was not there. Middle cardiac vein is in the posterior interventricular groove. Middle cardiac vein will be in the posterior interventricular groove. फॉस्फोवाइलिस वगैरह तो देखो, एक तरफ तुम क्वेश्चन पूछ रहे हो, दूसरी तरफ दूसरा कह रहा है कि 4 दिन चले। समय हमारे पास अभी तो कम है। हाँ, विष्णु प्रिया ने बता दिया पोस्टीरियर इंटरवेंट्रिकुलर ग्रूव में होती है मिडल कार्डिक वेन। एनीवे, आगे चलते हैं। पहले ही पूछ रहा हूं, ये क्वेश्चन था या नहीं था? अगेन इट्स अ रिपीट क्वेश्चन। Yes, Shubham Rathore, if you have patience, then I am the man. With me you should have patience, then I'll make you better in not only anatomy but other subjects also. But with me you should have some patience. Okay, so this is one question, and as you take your stethoscope for hearing the murmurs, if it is second intercostal space on the right side, it is aortic regurgitation, aortic stenosis. If you take your stethoscope on the left side, pulmonary regurgitation or pulmonic stenosis. If you take your stethoscope diaphragm and put in the fifth intercostal space near the cardiac apex, then it is mitral regurgitation, mitral stenosis. And if you take the diaphragm of your stethoscope left side, lower sternum, then it is tricuspid regurgitation, TR and TS sounds. So just remember that if it is second intercostal space, because aorta goes like this, that is why the murmur will be felt here. Second intercostal space, right, it is aortic. That is where you will see A2 P2, aortic second heart, and that will be P2, pulmonary second. So the pulmonary trunk, as you know, it goes this way. Pulmonary trunk goes like this. Pulmonary trunk goes this way, aorta goes this way. So pulmonary trunk goes this way, the murmur will be, or the heart sound will be felt here, and aorta is going this way, so it will be felt here. So A2 and P2, second heart sound, and even the murmurs, or murmur may be regurgitation or stenosis. So second intercostal space on the right is aortic, and second intercostal space on the left is pulmonary. If you are talking about the mitral, the blood is coming just like this. If we change the color, it comes like this. So since the mitral means from the left atrium to the left ventricle, the blood goes almost vertically down. That is why it is in the cardiac apex region, that is the mitral area. This is for the mitral valve or mitral area. and then this is the tricuspid. This is tricuspid. So tricuspid is the left lateral border of lower sternum. Left lateral border of lower sternum. So this is the tricuspid. That is mitral. So you can see A is, if you write, A is aortic and B is the pulmonary, C is the tricuspid and D is the mitral. So you can choose A aortic, B is pulmonary, C tricuspid, D mitral. Your answer is choice number B here. सश्रब्दा रॉय, ये क्वेश्चन का पूछ लिया था या फिर मैं कोई दूसरा एग्जाम दे के आ रहा हूं? क्या कैसे हो गया ये? देवाशीष और सश्रबदा, भाई तुम तो एक ही जगह से लग रहे हो, तो एक कह रहा है पॉइंट बी पूछ रहा है, दूसरा कह रहा है कि पूछा ही नहीं था, क्वेश्चन वाज नॉट देयर। यार कमाल, क्वेश्चन ही नहीं था, तो फिर क्या क्वेश्चन था? कुछ भी, छोड़ो फिर, जब था ही नहीं तो फिर क्या दिमाग लगाना है। ये देखो, ये था क्या? कैजुअल टॉक कह रहा है क्या सर कैजुअली टाइम खराब कर रहे हो हमारा? ये बताओ ये था कि नहीं था? सर ऑस्कल्टेशन के पर क्वेश्चन ही नहीं था। ठीक है, नहीं था तो नहीं था। ये बताओ ये वाला क्वेश्चन था कि नहीं था? चेस्ट पेन रेडिएटिंग टू अपर मीडियल आर्म था या नहीं था? जब पूछता हूं तब तो क्वेश्चन तब बताते नहीं हो, जब मैं बताना शुरू कर देता हूं उसका वक्त तो नहीं था। कैजुअल टॉक नो, स्ट्रेंजर टॉक्स यस, दोनों टॉक्स एक प्लस एक माइनस। कैजुअल टॉक नो, क्वेश्चन अलग था। क्या करें बताओ? शुभम घई कह रहा है। अच्छा एक चीज और है, वैसे हम इतने क्वेश्चन प्रैक्टिस कर रहे होते हैं, मतलब पिछले एग्जाम के लिए, हम इतने क्वेश्चन प्रैक्टिस कर रहे होते हैं कि केवल ऐसा होता है कि हमें लगता है कि था पर वो था नहीं, ऐसा भी होता है। तो एनीवे, डिस्कस करने में क्या दिक्कत है? फायदे की बात है। ये जो भी क्वेश्चन मैं लेता हूं ना, मेरा तरीका क्या है, मैं वो क्वेश्चन उठाता नहीं जो फालतू क्वेश्चन होते हैं। क्वेश्चन वही उठाता हूं जो मुझे लगता है क्लिनिकली रिलेवेंट है और जो हमारे एमबीबीएस बीइंग अ डॉक्टर हमें पता होना चाहिए। अदरवाइज इधर उधर के क्वेश्चन तो मैं अवॉइड ही कर लेता हूं अपने आप ही। तो अगर इफ यू आर टॉकिंग अबाउट दिस चेस्ट पेन एंड विच इज रेडिएटिंग टू द आर्म, देन इट इज, you will get these cases very frequently. Angina pectoris, upper inner arm, it is going. And why it is going? Let me just show you a diagram here. First of all, you should know that angina pectoris can refer to the upper inner arm. Angina pectoris normally is felt in the T1 to T4 dermatome. T1, T4 dermatome, because the root value of heart, sympathetic root value of heart is T1 to T4. So it will be felt in the precordium, there is no doubt. But then this pain can be going to epigastrium also, and it can be going to upper inner arm also. So going to epigastrium, retrosternal angina pectoris, and going to upper inner arm also. And not only upper inner arm, but even left basically. It can be going to right also, but usually left little finger. So why the pain is going there? Because of it is called referred pain. The viscera do not feel the pain, but the skin with the root value, same root value, will feel the pain. It is called referred pain. But anyway, why upper inner arm? That was the question. So intercostobrachial nerve with T2 root value. This is the territory. This is the territory. Upper inner arm. Upper inner arm. There is a nerve, intercostal nerve, T2 root value. It is going to supply upper inner arm. There is some anastomosis of the axons. So that is why intercostobrachial nerve is the reason which we can say the angina pectoris can be felt in the upper inner arm. And that is a good point for us, because any patient who tells that I have pain here and it is referred to this area, then you have to consider ECG immediately. And this pain can be retrosternal, this pain can be epigastric, this pain can move to jaw also. So this is all referred pain, because cardiac pain can be carried by cervical cardiac nerves. Cardiac pain usually is carried by thoracic splanchnic nerves, but the cardiac pain can be carried by cervical cardiac nerves, and it can also be carried by greater splanchnic nerve, greater splanchnic. If it is greater splanchnic, the pain will be felt in the epigastrium. So greater splanchnic, cervical cardiac, intercostobrachial nerve is the reason why the pain is not being felt only in the precordium, why it goes here, here or here. Here it is coming because of greater splanchnic nerve. There it is going because of cervical cardiac nerves, and there it is going because of intercostobrachial nerve. So in this question, our answer should be intercostobrachial nerve. Choice number A. Yeah, axillary lymph node dissection. If you talk about axillary lymph node dissection, you might damage intercostobrachial nerve. And if intercostobrachial nerve is damaged, sensory loss, upper inner arm, sensory loss. Okay, that question is coming. Yes, Samarth Vishnoi, that question is coming. So we move on to the upper limb only, as you are talking about. This is one question. Now, this question appears to be a little bit controversial because students have given different details, but I think this is what would have been the question as far as the data gathered from you all. Road traffic accident, nerve injury, right upper limb, able to carry, flexion at MCP, extension at IP. Is this the same question or not? फिंगर ड्रॉप था तब तो फिर सीधा ही आंसर हो गया. फिंगर ड्रॉप था और पोस्टीरियर इंटरओशियस नर्व था तब तो सीधा ही आंसर हो गया. But the thing is, if he is able to do MCP flexion and IP extension, it is because of lumbrical and interossei, and if lumbrical and interossei are working, median nerve and ulnar nerve are working. If this patient can do MCP flexion and IP extension, this is the function of lumbrical interossei. And if lumbrical interossei are working, that means median and ulnar nerve are working. That means in this question, you cannot take your answer as median and ulnar nerve, because they are the one who supply lumbrical interossei. Lumbrical interossei, they do two functions, MCP flexion and IP extension. If these two functions are there intact, that means both the nerves are intact. So ulnar nerve and median nerve, they supply lumbrical interossei, and lumbrical interossei, they work for MCP flexion, IP extension. And if the patient is able to do that, that means both the nerves are intact. So then you are left with radial nerve or anterior interosseous nerve. Anterior interosseous nerve, even if anterior interosseous nerve was given, you are telling it is not given, posterior was given, but if anterior interosseous nerve is given, then you will have problem with finger flexion, these two fingers. These two fingers flexion will be problem because anterior interosseous nerve supply FDP muscle, flexor digitorum profundus of these two fingers, and you know this hand, that hand deformity is there. So that can happen in anterior interosseous nerve injury, but the patient is able to flex. all the fingers. So cannot be anterior-interosseous nerve. So only possible, if these were the choices, only possible answer radial nerve. And if radial nerve was not there, if posterior interosseous nerve was there, it is still good, posterior interosseous nerve. Now you may ask, if posterior interosseous nerve is compromised, then how come patient is doing interphalangeal extension? If posterior interosseous nerve is compromised, if radial nerve is your answer or a branch of radial nerve, posterior interosseous nerve, how the patient is doing interphalangeal extension? It is possible because of lumbrical interosseae. It is understood that radial nerve is the one nerve for extension, and it is the radial nerve which is working for interphalangeal extension. And normally thinking, if radial nerve is not working, interphalangeal extension should not be working. But why interphalangeal extension is still working? Because it can also be done by lumbrical and interosseae. Lumbrical interosseae, they can do interphalangeal extension. So this is one concept which you should know. Otherwise, if this is the question, your answer will be radial nerve. If radial nerve was not in the option, posterior interosseous nerve was there in the option, it's a branch of radial nerve, that will be your answer. Finger drop was there. Finger drop at which joint? Must be MCP joint. Finger drop at MCP joint, not the IP. IP is working, MCP is not working. So finger drop means that finger drop will be at MCP joint, knuckle joint. So I have given you a little bit of detail, but okay. So radial nerve was there, fine, then radial nerve should be the answer. But posterior interosseous nerve is also there. Now, if you have to choose between the two, I'll go for posterior interosseous nerve. It becomes more specific. Because if radial nerve is injured, you will have some sensory loss also. And if radial nerve is injured, radial nerve means if both of them are given, radial nerve means you might have some problem with the elbow extension also. If it is radial nerve injury, radial nerve means till here it is radial nerve. So if radial nerve is injured, you might have problem with elbow extension also. But nothing is given about elbow extension. So among the two, this becomes preferable, because posterior interosseous nerve works only on posterior forearm muscles. Posterior interosseous nerve work only on posterior forearm muscle. It doesn't work on elbow. In this question, nothing is mentioned about elbow. But if radial nerve is involved, elbow will have some problem. So as such, in these options, radial nerve is the answer. But if posterior interosseous nerve was there, it will be still better answer. And with radial nerve injury, you will have sensory problem also. No sensory problem is given. They have not mentioned any sensory problem. Radial nerve injury means there will be some sensory problem. But posterior interosseous nerve is a pure motor nerve. It is a pure motor nerve. And since it is a pure motor nerve, there will be no sensory loss if it is injury of. So the best possible answer for this question would be posterior interosseous nerve. Yes. Okay. Just for the sake of discussion, you should know this is hand of benediction, median nerve injury, unable to fold the MCP joint here. These two fingers, finger number 2 and finger number 3, even finger number 1, that is thumb. This is ulnar claw hand, ulnar nerve injury, and that is of course wrist drop and finger drop, that is radial nerve. So if you have median nerve injury, these two fingers, you tell the patient to make a fist, cannot make. Tell the patient to make a fist, cannot make. These 3 fingers cannot fold because they are folded by the median nerve. So hand of benediction, and ulnar nerve, ulnar claw hand, and that is radial nerve, wrist drop, finger drop at MCP joint, not the IP joint, at MCP joint. Now some student will say, sir, these are same thing, they are same patients. No, they are not same patients, they are different. Ulnar claw hand means hyperextension at MCP joint, but here there is no hyperextension at MCP joint. If it is ulnar nerve, ulnar claw hand, you will have hyperextension at MCP joint. In ulnar claw hand, you will have hyperextension at MCP joint. There is no hyperextension at MCP joint in median nerve. It is flexion. MCP joint is in flexion. So this is median nerve, hand of benediction, and that is ulnar nerve, ulnar claw hand, and that is radial nerve. हाँ, फिंगर ड्रॉप को सोचकर आपने पिन मार्क किया, बहुत बढ़िया किया, आपका आंसर सही हो गया. ओके, ये क्वेश्चन था मेरे ख्याल से आप जिसकी बात कर रहे थे. Yes, Devashish Bhanja, that is what happens. Your FMGE exam is also becoming more like this NEET PG exam, INI-CET exam. All the 4 options can be answered, but you have to choose the most appropriate. Okay, so this question was there, and first thing is overhead abduction will be a problem because that is trapezius is not working, and second thing, shrugging of shoulder is a problem. Trapezius is not working. So if trapezius is your focus, then your answer will be spinal accessory nerve. That is the nerve which is compromised, spinal accessory nerve, which supplies the trapezius, and trapezius has a lot of functions. One of the function is overhead abduction, and second is shrugging the shoulder, shrugging of shoulder. So as the question is telling, overhead abduction is a problem and the difficulty shrugging the shoulder is a problem. That is the 2 function of trapezius which is supplied by spinal accessory nerve. So answer should be choice number A. Okay, so that was in the upper limb. Now we move on to the abdomen region. In the abdomen region, they are, tell me, was this question there? Some ligament was marked in a transverse section of the abdomen. Okay. Mental foramen matlab foramen of Monroe, omental foramen, epiploic foramen, spleen and abdomen, linorenal ligament. So this is a transverse section of the abdomen region. This is the vertebral body here. You can see the vertebral body. This is the vertebral body. If this is the vertebral body, then in front of that will be the aorta. This is the aorta. If that is the aorta, then slightly to the left side, slightly to the right side, lever, so right side is inferior vena cava. Let me mark. So as you mark, this is the inferior vena cava, that is the abdominal aorta, this is the vertebra. These are the kidneys, kidney on the right side, kidney on the left side, and this is liver, that is stomach, and this is spleen, that is spleen. So first of all, you should be able to identify the various organs. So vertebra, psoas muscle, kidney, the right kidney, left kidney, abdominal aorta slightly to the left, inferior vena cava slightly to the right, and this is liver to the right, stomach and spleen, and that is the arrow mark. If this is the arrow mark, then this is renal and splenorenal ligament basically. Splenorenal, or you can say linorenal. Linorenal, splenorenal is same, and the other ligament which relates with the spleen is splenogastric. This is splenogastric. So spleen has 2 ligaments. One is the splenogastric, as the name is telling, splenogastric, stomach, and the other one is splenorenal. This one is splenorenal, or leno-renal. So I think they were asking about splenorenal or leno-renal. And this will have the artery given by abdominal aorta. So abdominal aorta will give you artery and it will go to the spleen. It is called splenic artery. So when the abdominal aorta is giving artery to spleen, it is called splenic artery, is carried by the splenorenal ligament or leno-renal ligament, and then splenic artery will give branch to the stomach, and that branch is called short gastric artery, and short gastric artery will be carried by gastrosplenic ligament. So two names you can remember. Abdominal aorta was giving artery to spleen, splenic artery, and that splenic artery was carried by splenorenal ligament. Now the splenic artery itself gave branch to the stomach. It is called short gastric artery, and that short gastric artery will be carried by this ligament, which is splenogastric ligament. It will going to the greater curvature of stomach. This is going to be greater curvature of stomach. So some detail, but anyhow, if this was the question, they are asking about the mark ligament, means the arrow mark ligament. It is between spleen and the kidney. So leno-renal ligament is your answer. And the leno-renal ligaments not only contain the splenic artery, it will also have tail of pancreas. Tail of pancreas. Tail of pancreas goes to hilum of spleen. And when the tail of pancreas goes to hilum of spleen, it will run in the same ligament, leno-renal. That is why when you are doing splenectomy, you want to remove the spleen. When you do splenectomy, you have to ligate the splenic artery. But when you ligate the splenic artery, don't damage the tail of pancreas. Touching pancreas means you are inviting trouble. Should not touch pancreas at all. If you touch pancreas, it will be irritable, pancreatitis and all that. So when you are removing spleen, you have to be careful about tail of pancreas and don't touch the tail of pancreas. And tail of pancreas also runs with splenic artery in the leno-renal ligament. So when you want to remove the spleen, you have to ligate the splenic artery. Be careful about tail of pancreas because both of them are in this ligament. Some applied anatomy. So Devashish Bhanja is telling, Shubham Ghai, ये question आया था. स्प्लीनोगैस्ट्रिक पूछा था या स्प्लीनोरीनल पूछा था? कहीं और मार्क था, कहाँ मार्क था ये तो बता दो. पिक्चर वॉज इन ओमेंटल फोरामेन, इमेज उल्टा था, तो मैं अपने टीवी को उल्टा कर दूं? इसको उल्टा कर सकते हैं, वैसे कोई ऐसी दिक्कत नहीं है. एपिप्लॉइक फोरामेन पे था, तो एपिप्लॉइक फोरामेन पे अगर था तो ये होगा, ये रहा एपिप्लॉइक फोरामेन. यहां पे था क्या? अगर वहां पे था तो लेसर मोमेंटम आंसर हो जाएगा, देख लो, तब लेसर मोमेंटम हो जाएगा, क्योंकि लेसर मोमेंटम का नाम क्या है? हेपेटोगैस्ट्रिक लिगामेंट. अगर आप कह रहे हो एरो यहां था, अगर आप कह रहे हो एरो यहां था, तो ये फिर लेसर मोमेंटम है. लेसर मोमेंटम का दूसरा नाम क्या होता है? हेपेटोगैस्ट्रिक लिगामेंट. हेपेटोगैस्ट्रिक लिगामेंट ये है एपिप्लॉइक फोरामेन ऑफ मॉनरो, एपिप्लॉइक फोरामेन ऑफ विंसलो, एपिप्लॉइक फोरामेन ऑफ विंसलो. तो यहां पे था क्या एरो? आर यू श्योर? नहीं, इमेज को उल्टा कर लो, उससे कोई फर्क नहीं पड़ रहा. ऑप्शन में भी एपिप्लॉइक फोरामेन था, तो फिर लिगामेंट कैसे क्वेश्चन पूछेंगे अगर फोरामेन था तो? पेशेंट को प्रोन, जितने तुम्हारे एफएमजी के क्वेश्चन आते हैं पेशेंट को प्रोन करके पूछते हैं. वो पिछली बार भी एक क्वेश्चन आया था प्रोन करके. जरूरत क्या है प्रोन करने की? पेशेंट को सुपाइन रखो ना, प्रोन क्यों कर रहे हो पेशेंट को? एक और क्वेश्चन आया था, उसमें भी स्टूडेंट ने कहा कि सर वो तो उल्टा पूछा हुआ था. उल्टा, जब कन्वेंशन ये है तो पेशेंट को उल्टा क्यों कर रहे हो जबरदस्ती? या तुम्हें ही कंफ्यूज करने के लिए कि ठीक है तुम्हें ही कंफ्यूज, वर्टिब्रा ऊपर पहुंचा दिया मतलब, है ना? ठीक है. एनीवे, अगर स्प्लीन देखो, वर्टिब्रा जहां होगा वहां पे किडनी होगी, किडनी के साथ स्प्लीन है तो वो हो गया स्प्लीनोरीनल। स्प्लीन और स्टमक के बीच में हो गया स्प्लीनोगैस्ट्रिक। अगर स्टमक और लीवर के बीच में हो गया हेपेटोगैस्ट्रिक। ये एंटीरियर एब्डोमिनल वॉल की तरफ चला गया अभी। और अगर बिल्कुल यहाँ चला गया, अगर यहाँ पे कहीं पूछ लो तो फैल्सीफॉर्म लिगामेंट हो जाएगा। फिर वो फैल्सीफॉर्म लिगामेंट हो जाएगा बिकॉज नाउ द लीवर इज अटैचिंग टू एंटीरियर एब्डोमिनल वॉल। लीवर अटैचिंग टू एंटीरियर एब्डोमिनल वॉल, दैट विल फैल्सीफॉर्म लिगामेंट। ये दोनों जो है वेंट्रल मेसेंट्री में डेवलप होते हैं। दे कम फ्रॉम वेंट्रल मेसेंट्री एंड दे डेवलप इन डॉर्सल मेसेंट्री। दिस इज डॉर्सल मेसेंट्री। ये दोनों डॉर्सल मेसेंट्री, स्प्लीन की दोनों लिगामेंट डॉर्सल मेसेंट्री में होती हैं और जो लीवर की दो लिगामेंट हैं वो वेंट्रल मेसेंट्री में होती हैं। तो अब आप डिपेंड कर रहा है कि आपका एरो किधर था। लिगामेंट नहीं था, क्वेश्चन में ही लिगामेंट नहीं था। अगर क्वेश्चन में ही लिगामेंट नहीं था तब तो फिर कॉम्प्लिकेटेड क्वेश्चन हो गया। फिर तो फोरामेन भी, अगर फोरामेन में ही उसने एरो डाल रखा होगा तो एपिप्लॉइक फोरामेन भी आंसर हो सकता है। इफ ही इज पुटिंग एरो इन एपिप्लॉइक फोरामेन। एपिप्लॉइक फोरामेन है क्या? लीवर और स्टमक के बीच में है। आपको स्टमक के पीछे जाना होता है। आप स्टमक के पीछे लेसर सैक में जाना है। अगर आपको लेसर सैक में जाना है ग्रेटर सैक से तो वही है फोरामेन। तो then the answer could be epiplec foramen also. Then it depends that where was the arrow. If ligament was not there, then it is a complicated question. Anyway, I have tried my best. See, this is how it is. You are looking from inferior to superior, and you can see same details again. This is the aorta, this is inferior vena cava. यहां था, ये था क्या एपिप्लॉइक फोरामेन? यहां पे था क्या एरो? एपिप्लॉइक फोरामेन यहां पे एरो था क्या? अभी हमने जो बात करी है वो हमने बात करी है इस लिगामेंट की और इस लिगामेंट की। इसका नाम है स्प्लीनोरीनल, इसका नाम है स्प्लीनोगैस्ट्रिक, स्प्लीन से रिलेटेड। सो दे आर डेवलपिंग इन डॉर्सल मेसेंट्री, दे रिलेट टू स्प्लीन, स्प्लीनोगैस्ट्रिक, स्प्लीनोरीनल. If the arrow was with spleen, fine. If it was not with spleen, if it was here with stomach, then this is lesser omentum. It relates with epiploic foramen of Winslow. So if arrow was here, then your answer could be epiploic foramen. You move from greater sac to lesser sac. If you move from greater sac to lesser sac, you pass through epiploic foramen of Winslow. Sometimes what happens is there is pus behind stomach, and if there is pus behind stomach, it is pus in the lesser sac, and if you want to drain that pus, you take a tube and the tube will pass through the foramen of Winslow and then it will be put here to remove the pus. Then you have to pass through epiploic foramen. So maybe, as you are telling, the arrow mark could have been in epiploic foramen. And related to that is, this is lesser omentum, or what you call hepatogastric ligament, because that is liver. This is stomach, so hepatogastric ligament. Hepatogastric ligament is a part of lesser omentum. So I think it was little bit detailed. पिक्चर उल्टी थी, मतलब इस लेडी को उल्टा लेटा दो, पर आप लेडी को उल्टा लिटा ही क्यों रहे हो? ये FMGE वाले कुछ ज़्यादा कॉम्प्लिकेटेड केसेस देखते हैं लगता है. Okay, now this was a question, was CT scan based or was it just a simple diagram of lever? Cavernous segment. They have asked you about lever segments. Cavernous segment. So was it a CT scan picture or simply lever given? Okay, if it was not CT, then it will be simple. So when you look at the lever 8 segments, segment 1 is very small, cannot be seen from the front, it is hidden. Otherwise 2, 3, 4 and in a sequence you have to go if you look from the front view, you can see here, if you go from the front view, you have to go clockwise from the front view, If you are counting from the front view, go clockwise, but one cannot be seen because one is very small, caudate lobe, it is behind. So one is behind, otherwise 2, 3, 4 left lever, 5, 6, 7, 8 right lever. And if you know that, then you can see where the arrow was and accordingly you can answer. So segment 1 is hidden posterior to the 4. 4 becomes large, and in fact 4 becomes 4A and 4B. So this 4 is 4A and 4B, 4A and 4B. 1 is behind 4A. If you want to see 1, it is behind 4A. So this is 4. This entire is 4, entire segment. But then this is the left lever, this is right lever. So 1, 2, 3, 4 is left lever surgically, and 5, 6, 7, 8 is the right lever. So it becomes easier. This is how it is. Segment 1 is very small and it is hidden behind 4A. 4 is very large, it has 4A, 4B, but it belongs to left surgical lever. So 1, 2, 3, 4, 5, 6, 7, 8 in a clockwise fashion. If the arrow was here, that means they were asking 8th segment. I think that was the question. Okay, they had put some cartoon lever. Okay, fine. So you can see 1 cannot be seen from the front view. What you see is 4, but then 2 and 3 is also there. This is left surgical lever. And then you go clockwise, 1, 2, 3, 4, 5, 6, 7, 8. But don't think it is a 2D thing, it is a 3D thing, it is 3-dimensional. What you see here anteriorly will be 8 and 5, these will be posterior, they are posterior, these are posterior, these are anterior. Anterior and medial, posterior and lateral. These are anterior and medial, these are posterior lateral, because this is a 3D diagram basically, and in a cartoon diagram you cannot actually make 3D. So they are making themselves a cartoon and making cartoon of you also, because lever is not a 2D thing, it is a 3D thing. But anyway, I think they were asking segment 8. So you should have answered 8, I believe, that was the, because this question was INI-CET question in fact, and it was one CT scan image, and identifying in CT is different. Though concept is same, but it will be different. But anyway, if they were not asking you this, then we should not bother. Okay, what about this? This was the question there. Patient underwent surgery for indirect inguinal hernia. You want to discuss CT? It will be taking a lot of time. In CT, what will happen is, CT different levels can be taken, but one is at a upper level where you have the hepatic veins, and one is at a lower level where you have the portal vein differentiation. So upper lever you have more differentiation of hepatic veins, and lower lever you have more differentiation of portal vein. If it is upper lever, then you will see the segment 2, 4A, 8 and 7 like we saw, that counting is clockwise. So here only the upper segment will come, 2, 4, 4A and 8 and 7. So the same thing will be there. So the CT scan can be seen at 2 levels, and this is upper level where you have the hepatic veins, and then you can take it at the lower level also where you have the portal vein. So when it is in the portal vein level, means at a lower level, now the numbering will change because 3, 4B, 5 and 6 will come. 3, 4B, 5 and 6 will come. So 3, 4B, 5 and 6. But how will you know in a CT scan that it is at a lower level? Because at upper level you will not see this much of detail. This is too much of detail. This too much of detail where you have inferior vena cava, caudate lobe and all those portal triad and all that thing has come. In the upper level it will be simple diagram. You see here the hepatic veins are converging on inferior vena cava, caudate lobe is not that prominent. So you see this appears very simple diagram when you are at upper level, at the level of hepatic veins. The hepatic veins, these are hepatic veins, 3 hepatic veins, left, middle and right hepatic veins draining into IVC. So simple diagram, upper lever, and it appears little bit complicated now. So lower lever at the level of portal vein demarcation. So lower means then you have to look at 3, 4B, 5 and 6. 3, 4B, 5 and 6 lower lever, 3, 4B, 5 and 6. So I have mentioned the detail also. In PDF you can go through the detail. So what about this question? If they are putting some mesh, it might be including some nerve sometime. But if you are talking about the injury while surgery, it will be different nerve. So yeah, and in here also there are two, sometimes they will ask you whether it is an open hernia repair or laparoscopic hernia repair. But anyway, they have not mentioned anything like that. They are just telling patient underwent surgery for indirect inguinal hernia and some mesh was put and then most commonly damaged nerve. Because in this no options are given like lateral cutaneous nerve of thigh, so best answer is ilioinguinal nerve. But then you should have some more detail. Here the answer is ilioinguinal, no problem, but you should have this with you, this detail with you. And what it tells you is that if it is endoscopic nerve entrapment, means laparoscopic, then lateral femoral cutaneous nerve is the most commonly involved, more than genitofemoral or main trunk of the femoral, which is rare to be involved, means this nerve is involved. This is number 1. But then if it is, open repairs, if you are talking about the open repairs, then ilioinguinal is your first answer. This one, ilioinguinal is basically upper medial thigh is ilioinguinal, upper medial thigh. So laparoscopic surgeries, if you are talking about laparoscopic surgeries, lateral cutaneous nerve of thigh or the one which gives you myalgia paresthetica, those problems, myalgia paresthetica problems, if it is endoscopic or laparoscopic. And if it is open surgery, like maybe the question which came to us was about open surgery only, then ilioinguinal, upper medial thigh. So that is lateral thigh, that is upper. But in this particular question, I believe, because there was no lateral cutaneous nerve of thigh, so the only possible answer is ilioinguinal nerve. Genitofemoral was there. Ilioinguinal was not in the option. Then what was there? Ilioinguinal was there. Because before I put all these questions, I go through even the discussions which were made by surgery people, Dr. Pritesh and a few more surgeons who already have taken sessions. So they have discussed it, and ilioinguinal nerve was there in the option. Not only in RP people, but surgery people also, they have discussed it. I have gone through those discussions before I came in front of you, just to make sure that we are making minimal mistakes in the recall. But there will be mistakes always. Recall cannot be foolproof until FMGE people give us the paper only. You should put a court case, after a court case, after that put another court case that give us the paper also. Was this question there or not? Bartholin cyst. Options were different, okay. But was the answer same? Bartholin cyst, labia majora, anterior 2/3 and posterior 1/3. Was this the answer or was there some other answer? Posterior 1/3, okay. Bartholin cyst was not there. What was there? Then what was the question? Devashish, I think you went through some other exam hall, gave some other paper. In all the questions you are telling this was not there, this was not there. You got paper B, I believe. If Bartholin cyst was not there, then what was there? Something related to Bartholin. What is related to Bartholin? Bartholin duct. Anyway, it was related to Bartholin, isn't it? If it was related to Bartholin, let us just look at this. This is Bartholin cyst. So, this is the location of Bartholin cyst. You have to put the female in lithotomy position and look at the labia majora, divide the labia majora into 3 parts. So, this is the labia majora, divide the labia majora into 3 parts and you will see that wherever the junction of anterior 2/3, posterior 1/3, that is where you have the cyst. This is labia minora, that is labia majora. So, labia majora, you divide the labia majora into 3 parts, the junction of anterior 2/3, posterior 1/3, that is where you will have the Bartholin gland cyst. Lithotomy position, and this is the cyst. And to give you more idea, this is how it is. Lithotomy position again, and this is the location where you have got the great vestibular gland of Bartholin. Great vestibular gland of Bartholin. It is giving some secretion just to keep the mucosa moist. So, that is the location. This is the location. And here they have stretched it. This is the clitoris and that is the urethra shifted away from the midline, the skinny gland, and this is where you have Bartholin. So, it is more posterior, that is the vagina. You can say it is basically 5 o'clock and 7 o'clock, 5 o'clock and 7 o'clock, 5 and 7. And then lower limb. In lower limb you had this question. Somebody who is being checked for Trendelenburg test. Normally, if a person is okay, then the level of anterior superior iliac spine will be same. You put your thumb on the anterior superior iliac spine on the hip bone and it will be same. But if there is a problem, then you see it is tilting now, this level is going down. As the foot goes into air, gravity pulls it down. Anti-gravity muscle on this side are not working. Gluteus medius, minimus are not working. So, this will be left-sided Trendelenburg test positive. Normally, anterior superior iliac spine, you put your thumb there, they are at the same level. But when the person is standing on one foot and raising the other foot, gravity is pulling it down and you are unable to prevent that fall, that pelvic tilt, because normally it is prevented by other sided muscles. So this is basically left sided Trendelenburg test positive, right hip is falling down, they will be walking with a lurching gait now. So now the thing is, which muscles are you talking about? We are talking about gluteus medius and gluteus minimus. And what are their actions? Their actions are three: abductors, medial rotators, and stabilize the pelvis while walking. So we are talking about Trendelenburg test here. Gluteus medius minimus, their actions are abductor, medial rotators, and stabilizers of the pelvis, especially while walking, anti-gravity muscles. They are anti-gravity muscles. They balance the gravity. But if they are not working, then gravity is more powerful. It will pull the pelvis down, tilting of pelvis down. So abductors is your best possible answer. Abductors. Okay. Picture was different, but was it Trendelenburg test or not? Okay. So it does not matter, whatever the picture was, you should have the concept that normally when the foot goes into air, gravity pulls the pelvis down, which is balanced by the opposite side glutei muscles, medius and minimus. If they are not working, like polio, patient may have polio, or it may be fractured neck of femur, congenital dislocation of hip. So congenital dislocation of hip or polio affecting superior gluteal nerve, polio affecting superior gluteal nerve, or fractured neck of femur, these are some reasons Trendelenburg test can become positive. And such a patient, the limb length will be more, and then he will drag his foot. So he will start lurching, he will have a lurching gait now. So Trendelenburg test positive on left side. Left muscles are paralyzed. Left system is not working. Okay. Then you have got a question here, venous section, which nerve? I think this is, most of them are repeat question only. So was it there or not, or was it in a different format? You are doing venous section and you want to, Burns injury means great saphenous vein. Mostly these patients we search for great saphenous vein, and if it is great saphenous vein, along with that comes the saphenous nerve. And something like this. I think they gave you some relation with the medial malleolus also. Medial malleolus 2.5 centimeter anterior to medial malleolus, something like that. So vein will begin medial marginal vein, continue as great saphenous vein like this, drain into femoral vein. Medial marginal vein, continue as great saphenous vein to drain into femoral vein, and it will be medial marginal vein continuing as great saphenous vein like this, and saphenous nerve is lying anterior to the vein. So this is the saphenous nerve and it lies anterior, it is lying anterior to the vein. So when we are doing the venous section, we should be careful about this nerve. If you damage it, then there will be sensory loss at the medial malleolus, dorsum of the foot, and medial leg. This is the territory. This territory will be involved. Medial leg, medial malleolus, dorsum of the foot medially, not reaching great toe. It does not supply great toe. saphenous nerve do not supply great toe. So before that, dorsum of the foot, medial malleus, and this territory will be compromised if you have saved your patient. It was a Burns patient. You saved your patient, but you damaged the nerve. So after some time, patient will complain that I have sensory loss in this region because you were not careful to take care of this saphenous nerve. Journal surgery done at level. Not there. This question was not there. तो भाई इस हिसाब से तो कोई क्वेश्चन था ही नहीं, मतलब मैंने ऐसे ही सारे क्वेश्चन इकट्ठे कर लिए. ये था कि नहीं था? हाँ तो ठीक है. पेरिफेरल वस्कुलर डिजीज, बर्जर डिजीज का पेशेंट आपके पास, पेरिफेरल वस्कुलर डिजीज, बर्जर डिजीज, थ्रोम्बोएंजाइटिस ऑब्लिटरेंस, पेरिफेरल पल्स चेक कर रहे हो. मीडियल मेलस के पीछे तो पोस्टीरियर टिबियल आर्टरी. मीडियल मेलस से आगे जाओगे तो एंटीरियर टिबियल आर्टरी. उसको और कंटिन्यू करोगे तो डॉर्सलिस पीडिस आर्टरी. इस वक्त यू आर palpating deep to flexor retinaculum behind medial malleus. So behind medial malleus, deep to flexor retinaculum, it is posterior tibial artery like this. So this is the artery we are palpating, posterior to tibia, posterior tibial artery, passing under flexor retinaculum on the medial ankle. This is medial ankle. So medial side of the ankle, and you are palpating for an artery which is running posterior to tibia, then it divides into medial lateral plantar artery in the sole. So it will be dividing into medial and lateral plantar artery in the sole, but before that it is passing under flexor retinaculum. So that is the artery which you palpate for a case of peripheral vascular disease like Berger disease. If you are palpating here anteriorly, it will be anterior tibial artery, and the same anterior tibial artery further will continue as dorsalis pedis artery. So if you are anterior to medial malleus, it is anterior tibial artery continuing as dorsalis pedis artery. If it is behind medial malleus, it is posterior tibial artery because tibia is here. You are going anterior or posterior. Posterior tibial artery in the sole, it will give medial lateral plantar artery to supply the sole. टेन क्रिटिकल क्वेश्चन में एक इजी क्वेश्चन था मूड ठंडा करने के लिए. ठीक बात है. ग्रेट saphenous nerve surgery done at the level of, what is this? Devashish Bhanja. Great saphenous nerve surgery done at the level of. Great saphenous nerve की सर्जरी कौन करता है? Great saphenous vein. Great saphenous vein surgery done at the level of. तो आगे पीछे बताओ at the level of क्या? ऑप्शन क्या थे? ठीक है. This is the last question I have got. So the show is over. Maybe I had 20 questions, but out of 20 questions only MSK, hello sir. अच्छा अभी हेलो करने का टाइम आ गया. तो जितने भी क्वेश्चन हमने डिस्कस किए उसमें से 70% क्वेश्चन तो थे ही नहीं आपके अनुसार. नो सर, क्वेश्चन वाज लाइक ग्राफ्ट कहाँ से लेंगे समथिंग. ग्राफ्ट कहाँ से लेंगे? ग्राफ्ट तो कहाँ से लेंगे? ग्राफ्ट के लिए तो आपको पूरी की पूरी वेन निकालनी होती है. अगर आपको ग्राफ्ट लेना है, आप यहाँ से इसको हमारे टाइम पे तो जो क्लच वायर होती है ना, क्लच वायर को डालते थे यहाँ से, ऐसे क्लच वायर डालते थे और खींच देते थे ऐसे करके, सारी की सारी वेन निकाल देते थे इसके लिए, कॉर्नरी आर्टरी बाईपास ग्राफ्ट के लिए। क्लच वायर आपने अगर मोटरसाइकिल चलाया हो ना, उसमें मोटरसाइकिल में क्लच वायर होती है, वो क्लच वायर यूज़ होती थी हमारे टाइम पे। आज से बात कर रहा हूँ 1998 की बात कर रहा हूँ। क्लच वायर डाल देते थे पेशेंट को और उससे खींच देते थे। क्लच वायर में उल्टी होकर वेन आ जाती थी वो, और फिर उससे यहाँ पे यूज़ करते थे कॉर्नरी आर्टरी बाईपास ग्राफ्ट के लिए। तो अब आप पूछ रहे हो ग्राफ्ट कहाँ से लेंगे? इफ़ यू वॉन्ट टू, इफ these days, now it is quite sophisticated, these days you will take it from this level, lower, this level, below knee. Now they use the graft which is below knee. तो ऐसा कुछ था क्या? बजाज स्कूटर बजाज स्कूटर की क्लच वायर। जब मैं तो पैदा ही नहीं होता। साहिल आलम, तो मेरी उम्र भी तो 52 ईयर्स का हूं मैं। ठीक है, कुछ तो हमने किया ही, ऐसा नहीं है कि कुछ नहीं किया। बट इट्स वेरी सरप्राइजिंग दैट योर फ्रेंड्स ओनली गेव दीज क्वेश्चंस and more than 50% questions you said they never came. So I don't know what is this called, deja vu or failure of retrieval system. But anyway, I hope the session was beneficial to you. As such, will help you becoming a better doctor. And anyway, you are going to clear your screening exam. That is not too much of a barrier. This time exam was a little bit on the easier side, I believe, and you have done well. And as I mentioned in the beginning of the class, the good news is awaited. लगता नहीं, क्यों वरुण? सबसे पहली चीज तो सारी कहानी कॉन्फिडेंस से ही शुरू होती है। कॉन्फिडेंस रखो, फिर होमवर्क करो। पहली चीज कॉन्फिडेंस, दूसरा होमवर्क करो। होमवर्क क्या है? कुछ नहीं है, प्रीवियस ईयर क्वेश्चंस करते रहो, प्रैक्टिस हो जाएगा, हो जाएगा। किसने बताए थे? कम से कम 50 स्टूडेंट हैं हमारे पास, प्रेपलैडर वाले बिठा देते हैं सबको। तुम बताओ, तुम बताओ। 6th आर्च क्लेफ्ट, 6th आर्च का तो क्लेफ्ट ही नहीं होता, क्लेफ्ट तो 4 ही होते हैं। सिक्स्थ आर्च क्लेफ्ट, क्लेफ्ट तो 4 ही होते हैं भाई। 6 फेंजल आर्च, 6 फेंजल आर्च में क्या है? 6 फेंजल आर्च में भी तो बताया, डक्टस आर्टीरियस, एक तो डक्टस आर्टीरियस, पल्मोनरी आर्टरी, रेक्टल लेंजियल नर्व, ये सारे 6 आर्च से ही हैं। 6 आर्च से अगर मसल्स पूछते हो तो लैरिंक्स की मसल से, नर्व पूछते हो तो रेक्टल लेंजियल नर्व है, आर्टरी पूछते हो तो पल्मोनरी आर्टरी है, इधर की तरफ डक्टस आर्टीरियस भी है, ये 6 आर्च है। ओके, चलो ठीक है, ऑल द बेस्ट। और मेरी शुभकामनाएं कि आपका भी जो भी मकसद है, मतलब काफ़ी कुछ तो आप वो लोग हैं जिन्होंने अभी एग्ज़ाम दिया है, कुछ मुझे लग रहा है कि नहीं भी हैं, वो क्या कर रहे हैं मुझे मालूम नहीं, लेकिन जो भी आप कर रहे हो मेरी शुभकामनाएं आपके साथ हैं, आप विजेता हो। ठीक है, ऑल द बेस्ट, टेक केयर, हैव अ नाइस इवनिंग, बाय।